Hi, welcome everyone. I am delighted to be moderating this event today with three superb speakers. I want to thank our co-sponsors for this event. I'm a professor at the University of Pennsylvania Carey Law School. I want to thank our co-sponsors, Penn Leonard Davis Institute and the Princeton Center for Health and Wellbeing, and also the Robert Wood Johnson Foundation. Thank you for your generous support of this event. So let me introduce our three panelists for today, and then I'll talk a little bit about the format for today's event. Katie Keith is a part-time research faculty for Georgetown's Center on Health Insurance Reforms. She's also a principal at Keith Policy Solutions, where she advises nonprofits and foundations on healthcare issues and conducts policy research. I'm sure many of you know her as the ACA guru on the health affairs blogs. I read her blogs regularly before I teach my health law class, so I make sure that I don't mess up any of the details. You probably know her work focuses on implementation of the Affordable Care Act, legal challenges to it, and its impact on underserved populations, such as the LGBT community. John Gruber is the Ford Professor of Economics at MIT and a celebrated voice on healthcare research and policy design. He was a key architect of the Massachusetts health reform effort in 2006. And then when that effort informed the creation of the Affordable Care Act, he served as a technical consultant to the Obama administration in 2009, 2010, and then worked with the administration and Congress to help craft the Affordable Care Act. His prolific academic research continues to illuminate both the potential of and also the limits of health policy reforms. Our third speaker today, Jim Caprera, has deep experience in public service and research. He is currently a resident fellow and holds the Milton Friedman Chair at the American Enterprise Institute. He was an associate director at the White House's Office of Management and Budget from 2001 to 2004. And earlier, he was a senior health policy analyst at the US Senate Budget Committee and at the US House Committee on Ways and Means. He's an expert on individual coverage and the exchanges, and also beyond. Some of his recent writing has focused on Medicare reforms and also how to scale up COVID vaccination efforts. So welcome to my three panelists today. I will direct questions at them for the first 35 or 40 minutes of this event, and then we'll open it up for your questions. We will be using the Q&A function on Zoom today for your questions, so type them in at any point, and after our moderated discussion, I will ask your questions of them. Okay, so welcome everyone. It is really nice to have the three of you here today. I want to start with a question for all three of you, which is the fact that as we look kind of back, we're 10 plus years after the passage of the Affordable Care Act. And as we look back now, it seemed like the two monumental coverage reform efforts were focused on Medicaid and the individual market. And both have rolled out in ways that were different than anticipated. But many people would say that the Medicaid expansion has proven higher impact in terms of who's covered and the number of people covered. So what is your assessment of the individual market reforms in retrospect? And maybe I'll start with you, John, on this one.
Sure. Thanks so much, Allison, and thanks for having me here. Let me just comment quickly on Medicaid. Remember, part of the reason Medicaid has been so successful, and I emphasize this in my work with Ben Summers and Molly Freen, has been this huge woodwork effect we didn't anticipate. A lot, probably our estimate is about 40% of the increase in Medicaid is actually people who are already eligible. So part of the reason sort of, if you sort of summarize CBO's scoring of the ACA is getting the number of covered right, but getting the mix wrong. They understated Medicaid and overstated the exchange. And part of the reason they understated Medicaid was because they didn't account for this huge woodwork effect, which has more than offset the fact that some states haven't expanded Medicaid. On the exchanges, I think that what we've learned is, and you can look at research by my colleague Amy Finkelstein in this, I think we've learned people a little more price sensitive than we thought they might be. We've learned the mandate that lessons from a state like Massachusetts don't apply to the nation as a whole, and that having a mandate, remember the mandate penalty was about half as large nationally as it was in Massachusetts. So having a mandate with a relatively small penalty that's politically contentious has a very, very different effect than a mandate in a state where the law passed universally, unanimously, and there was a high penalty. So I think the mandate turned out not to matter as much as we thought. I think we've also learned that policy matters a lot in terms of exchange premiums. And I think, and really everyone here should be reading Jonathan Cohn's new book, The 10-Year War, which is a terrific insider summary of development of the ACA. And he highlights something we haven't talked enough about, which was that part of the idea of the exchanges was to have a whole bunch of new options, these new co-op insurance plans, sort of the sort of compromised public option, if you will. And they had no idea how to price. So what we did is we set up risk corridors, building on the successful 2003 Part D reform. We set up a series of risk corridors so that if they got the price wrong, they would be subsidized. If their price was too high, they'd give money back. If it was too low, they'd get money. Unfortunately, those risk corridors were then undercut, it turns out illegally, by the Congress after 2010. So these companies, which were supposed to provide a lot of competition in the exchanges, faded away. You ended up with very non-competitive exchanges and high premiums. And I think you put on top of that, removing the individual mandate and the various other actions that the Trump administration and Congress took to undercut the law, like, ending funding for enrollment and offering more non-exchange options, you ended up, ironically, with the AC exchanges looking sort of like what Democrats would have wanted, which was just something for poor people. I mean, the whole idea of the ACA, as we envisioned originally in Massachusetts, was a combination of something for the left, which was subsidies for the poor, and something for the right, which was a well-functioning individual insurance market that the middle class could take advantage of. And ironically, the actions that were taken, over time ended up sort of scooping out the last part of that. And that's why, we'll talk about what comes next. That's why, these new sort of what's in the ARA in terms of, extending subsidies up the income distribution is potentially very important.
Great, thank you. Jim, over to you.
Well, there's obviously a lot of things I agree with that Jonathan just discussed. So in terms of the relative bang for the buck, in terms of what was put into the bill, obviously, in some ways, it's just a lot easier to expand an existing program than it is to stand up something else. And so if you were just taking an architecture of Medicaid and saying we're going to try to make a lot more people eligible for it, as an administrative matter, in technical matter, it's obviously just a whole lot easier to do that. And the truth is that, a big reason why a lot of people are uninsured in this country and were prior to the ACA was because they were very low income and they couldn't afford premiums, whether it was in the ACA or anywhere else. And so their interest in getting coverage was very high for Medicaid and maybe not so high if they had to pay a little bit of a premium out of their own pockets. In terms of the exchanges and how it's evolved and developed, I mean, I do think it's very important to highlight two things that Jonathan's already mentioned, but deserve some emphasis. One is that the just vast overemphasis on the individual mandate for the last decade. And it really has distorted a lot of policy debates. And it's kind of unfortunate because it maybe made it more difficult to get to some semblance of stability. That includes, by the way, CBO. Sometimes CBO is a great organization, but sometimes they do miss the mark, and they missed it on this one by a pretty wide margin. In terms of, and that had a huge effect on a lot of debate. In terms of the exchanges and how they've evolved and who's been attracted to them, I think the reality is that a big policy change that the Affordable Care Act put in place, and it was needed, but it had a huge effect on premiums distribution across the population, was just the narrowing of how much could be charged by plans in the individual market by a substantial margin. So it made it much more affordable for people with higher risks. And they joined the exchange, especially if they were low income. And it, predictably priced out some people who were getting pretty good deals in the old individual market. And the sorting that sort of set in motion has taken a while for everyone to kind of figure out where it's going. And, I think the bottom line of it is that if you're a moderate income person who's healthy and you were asked to pay the premiums that were charged in the ACA marketplaces in a lot of states, they just viewed it as just too high. And so they were looking for some safety, valve to get out of it. And they pushed to repeal the mandate, and they pushed for other options, and the Trump administration accommodated them to some degree. And so Now the question is, do we leave that alone, or do we try to reverse that and try to force them into the exchanges? I think that would probably be unwise. I think that probably leave them alone and try to make the exchanges work even better for the people that want to go into them.
Great, thank you. I want to ask about that next, but before we get there, Katie, you want to jump in on this first question?
Yeah, I would just say that, I think we also have to pay attention to some of the decisions made by the Obama administration. So, John mentioned sort of the risk corridors fight that happened in Congress. I tend to think that the decision to allow folks to stay in what we sort of have come to know them as grandmothered plans had a huge impact those first years. And that's why those risk corridors were so upside down and paying that out right. I think it really, for political reasons, mixed up the risk pool, and we didn't get what we expected. And it took years and years to really recover from that. So I think there's sort of across the board, liability there, or, everybody shares a little bit of blame for that one. I also think a lot about, if states had really taken up the invitation to adopt the Affordable Care Act to set up their own marketplaces, even setting aside Medicaid expansion after 2012, would you have had more states like Kentucky with Connect, which was very successful, where folks loved it? Would you have had better take up if you'd had, more partnership with the states really being willing to do this and make it work in their state? The states that have embraced the Affordable Care Act and done their own marketplaces have seen really successful enrollment, and it's been a popular program there. So I think some of the state reticence is maybe a diplomatic way of saying it on the ACA has push there. But I do want to emphasize too, even those early sort of rocky years, you saw, marketplace enrollment peaked in 2016. You had about 12.7 million enrollees. What else happened in 2016? You had a presidential election. And so you had this cycle where things were ramping up and ramping up. Every year it was increasing. And since then, we started to see declines based on sort of the policy decisions, I think, adopted by the Trump administration, coincided with the uninsured rate rising once again, and now we have a pandemic. So, yeah, well, one more point on that. Even with sort of that fall, I think we've bottomed out, right? I think we have seen that there's going to consistently be, 11 million people, at least through healthcare.gov, that need in good comprehensive individual market coverage. I think things only go up from here. And I don't think that's just sort of being driven by the pandemic. So I'm excited, I think, looking forward to seeing what could have been done even without the American Rescue Plan, but sort of watching that roll out in real time over the next 2 years too. I think it's going to really show what these markets can do.
So let me pick up on there and ask you all a question about this kind of looking forward. So we've seen the American Rescue Plan, and if you read the estimates on kind of the American Rescue Plan and the numbers of people it will bring into the exchanges, it's wonderful, but it's also, it still leaves a large number of people who are eligible who are not choosing to enroll in, in marketplace coverage and individual coverage. So as you look forward, and as you look backwards, because some of you are talking about some of the Trump administration policies and the effects that they've had on the choices that people have and on the exchanges. I'm being interrupted by the CLE passwords. A number of people on this call are getting CLE credit. So for you, watch for the passwords. The rest of you can just close them out. I'm glad those pop up when I'm speaking rather than when you're speaking. So, as you look kind of backwards at these policies and you think about going forward and the potential for the individual market, what level of effort do you think should be invested at this point in the individual market versus other venues for getting people insured, and what types of efforts, either in terms of preserving, rewriting some of the Trump administration policies, or kind of looking forward, what would be the ideal for, kind of maximizing the potential of these markets. And I will say that there are a number of people on this call who run these marketplaces, the people at the state level who are the, kind of the directors of the exchanges or insurance commissioners, and others who have invested heavily. So I think that they will both be, I warn you that both to know that there are people who've spent the past number of years with a great deal of sweat over getting these things to work well. But I think they'll be interested in your insights as well on kind of what to think about going forward. So Jim, let's start with you on this one.
Well, I think I've been working with Stan Dorn at the Families USA on this for a couple of years now, which is that and CBO had a very interesting couple of studies they put out in the last year on this, which is, who are the uninsured at this point and what are they already eligible for? And so my basic point of view is, before we start creating new things, let's try to do a better job based back onto this woodwork effect that Jonathan mentioned at the top, which is to try to get as many people who are already eligible for something into the program they're already eligible for in a very non-friction basis. So it doesn't take a lot of effort on their part, and they just get put into it and make it easy for them. And I think we could stabilize a lot of coverage that way. So for instance, Medicaid ought to be for everybody in Medicaid, maybe with possible exception of certain subpopulations, but for people that are on Medicaid for health insurance reasons, make it a 12-month thing, so that everybody that gets eligible just say, okay, you're on for 12 months and then we'll reevaluate at some point. This idea of sort of monthly income changes affecting your status for a health insurance program, it's too much, it's too much churn, it's too much instability. So I'd do that. I'd also create a automatic enrollment system using tax data as much as possible, so that people that are already eligible for free coverage through the Affordable Care Act premium subsidy system, and that'll be even more people now with the new law, put them into the free coverage and then allow them to opt out. They don't have to take it if they don't want it, but through income tax data, you could figure out pretty quickly, who's already eligible for something based on their prior year data. By the way, you could then couple that with moving the enrollment year from a January 1 to December basis to maybe May 1 to the following April 30th. So you get tax data in the spring, you figure out if someone was uninsured, you put them into a plan, and then they get to keep it for a year regardless of their income changes. So just make it a lot easier for people who are in that kind of a category to get the coverage. And then ask the employer community to start being more aggressive for automatically putting people into coverage also. Make that an option for employers. And then people opt out if they have spousal coverage, but if they don't have spousal coverage, make it a presumption that they'll be paying for their employer plan, and get them into their employer coverage also. So between those three options, Medicaid, the ACA, and employer plans, you're talking about 2/3 of the uninsured. And then a good chunk of those who are not in that 2/3 are people that, for whatever reason, some of whom came to the country a long time ago, but are here without proper documentation or not legal documentation to keep residing here. And then we still got to do something for them too, but maybe it's some hybrid thing that can be politically palatable to everybody, to say we should make sure they have health insurance coverage as well, and create something that allows them to opt into that. So anyway, those are a few of my thoughts on how to get the uninsured number even lower than it is.
Great, thank you. Katie.
It's hard to disagree with any of that. I completely co-sign what Jim said. We've got to make this easier for people. And I think, Allison, part of maybe the premise of your question was, it is sort of a small market, right? And while I am tired of fighting about the individual market, because it is a very small component of the market and getting so much emphasis, I mean, the pandemic to me just underscores why we have to sort of keep it up and keep making sure that this market stays healthy, that we make it easy for folks who need it to land there. It is likely to stay a transitional market for a while, for the immediate future, but having something catastrophic like this, and we didn't see we don't know, I guess, but we didn't see the sort of coverage losses that we expected to really materialize as a result of the pandemic. Employers kept offering coverage, or a lot of folks landed in Medicaid, I think, to Jim's point. But we have to have this as sort of part of the safety net, I think, and so continuing to invest in it and make it work. I think there's additional things like better linkages to unemployment offices. I mean, I think there's some sort of low-hanging fruit here that you could do to really make that safety net work better for people, and include the Affordable Care Act as part of that. It just hasn't, because of the politics around it, I don't think we've been able to talk about it that way in most states, but it really feels like time, especially with this new legislation, to be able to do that a little bit more.
John.
Yeah, those are great comments. And look, I really want to say Jim's comments are so inspirational, because it brings us back to the fact that I always call the ACA the most bipartisan law in history, in the sense the ACA did have a bipartisan basis. It became partisan, but folks like Jim and Stan Dorn working together, this can be, if we can somehow get past the ugly politics of being labeled Obamacare, there are good centrist ideas embedded here. And I think the individual exchange, which is really a conservative idea at its core, is key. We have to promote and continue. Remember, the single most important thing the ACA did was end insurance market discrimination. And the individual exchange is a key part of that. And we have to continue to promote it. I was disappointed that Congress even put COBRA subsidies in the latest bill. Let's not double down on the failed employer insurance market. Let's work on the individual exchange market, which could be a place where right and left actually sort of meet. So I love everything Jim said. I do think on auto enrollment, I do have one place I differ a little bit, which is I really worry about auto enrolling people who aren't getting stuff for free. I feel like, this is a big debate I had with other Obama advisors during the 2008 campaign where they said, we don't need the mandate, we can do auto enrollment. And I said, I don't understand why you think the politics of mandate's ugly, but the politics of enrolling someone in something that costs them thousands of dollars, the end of the year they get the bill and say, wait, I didn't want this, isn't even uglier. And it seems like you auto enroll people who owe money, you're back into the fight you had over the mandate. I think we really need, this isn't pensions where you put in a pension, everybody values it. This is health insurance where some healthy person may not want it and not value it. And they're gonna be thousands of dollars they're paying. So I really think what we need to think about is auto enrollment, exactly what Jim and Stan have been pushing through tax forms, move the open enrollment date, but I would also bump up at the bottom the set of people who can get insurance for free. I take the free up to 2 times poverty, and I don't enroll everyone up to 2 times poverty. Right now, it's free only to 1 times poverty in the exchange. I would take it free up to 2 times poverty, and let's auto enroll everyone. That would get a huge share. I mean, most of the uninsured are in that range. So if we could actually auto enroll everybody below 2 times poverty in a free plan, I don't think that has any backlash. And I think that that's absolutely the way to go. And I think that, Jim and Stan are doing terrific work on that. I think the other point I'd make, though, I want to emphasize, it's sort of a minor point, but I've really been focused on it in terms of the exchanges. Remember, it's not just about premiums, it's also about out-of-pocket costs. And, I'm a big believer in demand side cost controls in healthcare and in having cost sharing, but the cost sharing is just too large for the low income people in the exchange. People 150 to 300% of poverty can be spending 20 or 5 or 30% of their income a year on out-of-pocket costs plus premiums. So to remember not just to deal with this with premium affordability, which I think for low-income people, actually, I think the premiums are pretty affordable, but to make sure we address the fact that a silver plan just isn't good enough coverage for someone at 2 times poverty or where the cost sharing reductions run out. So that's just the other point I'd add.
That's great. This is super interesting, and I want to actually draw on a question that we got from the audience related to what you all are talking about. I mean, I think that it feels to me like the American Rescue Plan creates a lot of short-term but potential for the kinds of things you're talking about, because there'll be more people who have essentially free premiums depending on what plan they're enrolled in. So there could be the potential to kind of merge what John and Jim are talking about. And so then the question from and then there's a larger term question, which we'll get to in a moment, which is, will it become permanent? And how do we think about that? But there's a question from the audience, which it may not be fair to ask, but I'm going to ask it, which is that there's broad support in the policy community for the types of changes Jim is talking about to make it easy for people to be enrolled in coverage. How do we build political support for this? How do you build political support either at the state level or at the federal level for these kinds of changes? So I'll let Jim jump in, please.
Well, politics isn't really my forte here, so I don't know. I mean, the country's so polarized that it's a little bit hard to know how you build consensus around these things anymore. But I think for both sides, one thing I like to try to emphasize if I ever get a chance to talk to policymakers is I say that health policy is one of those things where you think you're gonna get a free pass to take your idea all the way to the end zone and spike the ball and so on. It just sort of never works out that way. It's way too complicated. There's too many existing institutions, and a lot of inertia and momentum behind what's already there. And so what you got to do is try to make what is there work as best you can make it work, and not kind of tilted ideological windmills too much. And that leads me to think that automatic enrollment and stabilizing the coverage that already is there is probably, something that, if you're interested in trying to get the uninsured rate down, which I grant there are probably even some Republicans that say, well, that's not an important goal for me, but I think it is an important goal for a lot of Republicans, and they ought to embrace that as probably the most straightforward way to make it happen. On the Democratic side, I mean, I kind of agree with some of the things Jonathan said, but on the one thing for the Democrats, I think, is there's 165 million people in employer plans, And I don't think that's going away, and so there's just a lot of momentum and inertia behind that, as you can see by the repeal of the Cadillac tax. So I just think that that's here to stay too. And so we need to make that work, however flawed it is, we need to make that work as best we can.
John, before you jump in here, I want to layer one more question in from an audience member, which is also to address consequences, economic or political, from raising the bar for people who can get insurance for free to 2 times poverty.
Yeah, so I think, I think Jim's exactly right. I guess I'm a big believer, based on the experience led to the ACA, that state experimentation can play a big role. I think Stan is already, which state, Jim? Is it Connecticut? One of the states is doing. Maryland is doing, is already implemented. I don't know how to apportion the credit between Stan and Jim, but has already apportioned auto enrollment plan. And
99 to 1, you can guess who was the one.
So I think more states need to do that. I think this conversation inspired me to go lobby my state to start doing more of that. So I think we need to really get more, once again, naturally, probably blue states will lead on this, but to get more states to do it. And I think that's the way you build political consensus. Making premiums free at the bottom, it doesn't cost a whole lot. Okay, we don't collect that many premiums. It will. And if you do it by itself, I don't think it scores as that much, because I don't think you bring that many more people in. But it opens the door to auto enrollment. And that's a big effect and a big coster, but very cost effective. The people you bring in are healthy. They're going to be cheap. Your bang for the buck will be super high. So I think it's doable. I think, clearly the Democrats want to build on the short-term ARA changes to have a more fundamental increase in generosity of subsidies through the exchanges. And I hope they'll make it cheaper at the bottom, not because I don't think people can afford to pay 2% of income. I think they can. It's less affordability concern and more that I think auto enrollment is the future. But I really think auto enrollment only works if it's free. Jim, your point on employer-sponsored insurance, I agree. We should get more people in. I just feel like it's actually that sort of a down. I'd rather make the exchanges work first than make auto enrollment work first at the bottom in the exchanges. If we can maximize the ease of signing people up for insurance at employers, I'm all for it. If employers want to independently set up auto enrollment in employer insurance, awesome, go for it. But I think a federal law which does auto enrollment is going to have the same problems the mandate did.
Yeah, I would make it if I could just add one thing. I know we got to let Katie jump in here, but I would just say I'd make it voluntary for the employer to jump in. In other words, create some federal safe space, so to speak, for them to do it. But they only have to do it if they want to. So they have to judge with their own workforce whether this is something they can sell to them or not.
Yeah, and I just want to remind folks, so American Rescue Plan did extend $0 premium, $0 premium contributions up to 150% of poverty. So we are getting closer to that 2 times poverty that we're all sort of interested in here. And, the changes in the bill, I think, certainly do focus on the premium tax credits, making those more generous both down and up the income scale, which we haven't necessarily talked about the middle income consumers yet either, and bringing them into coverage that's much more affordable. But what that also does is give an opportunity for better out-of-pocket costs. So folks who are now getting these $0 premium plans, they were in bronze plans, and so they can move from a 60% AV to 70%. I think I totally agree with John. Silver is not enough for low-income people, but I'm curious to see how much sort of plan shifting we see because of these more generous tax credits. I think it's an acknowledged or underappreciated point of what is happening with these premium tax credits, that it's actually going to help people in out-of-pocket costs if they come back to the marketplace, if they can figure it out, if we make it easy for them, which I know many of the state-based marketplaces and our federal friends are all working on right now too.
Katie, could you talk a little bit about, we've been alluding to the American Rescue Plan, and I know some people on this call have been following it closely and others probably less so. I know you have been following it closely and have been writing and talking about it. Can you talk us through a little bit about how the bill works to expand access to health insurance, and then especially affordability? We're starting to get a lot of questions about affordability, and kind of the point where you left off through the Q&A is that even people who have insurance have high deductible plans. We're seeing that increasing. So can you talk a little bit through the American Rescue Plan provisions and how they will have an impact on both access and affordability to coverage? And then I also, as you're talking about it, talk about the kind of the time frame for it and what you imagine will happen after after these provisions phase out.
Yeah, no big deal. Thanks, Allison. No, so there's sort of 4 key ACA provisions that I've been focused on that I think many of us are watching. The first one is this new bill gets rid of what we call the subsidy cliff. So under the Affordable Care Act, folks at about 400% of poverty, about $50,000 for one person, more for families of bigger size, wasn't getting any help. So middle income families who are purchasing their own coverage, I think have been sort of left out of this entire system that even John and Jim are talking about, of employer coverage over here and Medicaid and the individual market. Everybody else gets some help, and you have this group of middle income families and people who are on their own buying their coverage who hasn't gotten anything. So this bill gets rid of that. It sort of extends the premium tax credits that have been made available for folks at the lower end of the income scale to also benefit from that. And what it says is no one has to pay more than 8.5% of their income towards health insurance premiums. 8.5 is still a lot for some people, which we can talk about, but it does give some help. And so there were, who that really benefits is older Americans living in rural areas with high health insurance costs who are paying, they had coverage because they needed it, but they were paying out the nose for it. So you're going to see a lot of savings from those types of populations. The bill doesn't stop there, though. It also expands tax credits down the income scale. So folks who are already getting subsidies are getting more generous premium tax credits. It means they're paying less each month. And that's the part where we're seeing sort of the no premium contributions for folks at the lowest end of the scale. There's also sort of a unique provision that would tie anyone who receives unemployment benefits during 2021 would get maximum subsidies under the Affordable Care Act, maximum premium subsidies and maximum cost sharing subsidies. We still need to sort of get that implemented and see how that's going to work out. And then there's a separate provision on clawbacks, and 2020 was an impossible year for folks to have to estimate their income. Normally at tax time, you sort of true up and see, here's what I estimated, here's what I made. If I owe anything back, I have to pay it. I think Congress recognizes that was impossible for this year, and so they've sort of waived that requirement for 2020. I've already gotten many emails from consumers who have found the pieces that I've written who are so grateful that they don't have to pay back all of their tax credits for 2020, recognizing what a really huge challenge that was. So that's on the ACA side. The big enhanced tax credits are for 2021 and 2022. So there is going to be this cliff that comes in. The others are just for this year, more or less. John mentioned this too, full COBRA subsidies, 100% of COBRA subsidies through the end of September. So folks have some window there. It makes it even more complicated for folks to try to figure out what they're going to do, what type of coverage they're going to land in. And then there's a whole bunch of new incentives for states to expand the Medicaid program that are much more generous even than they would be getting under sort of 100% federal match. And then a whole host of other changes to the Medicaid program. So I'll stop there, but there's a lot in there. I think I would like to see all of that get made permanent. And I think Congress will be under a significant amount of pressure to make that happen. If not, you will see premium spikes right around November of 2022 as 2023 coverage rolls out. So right at the midterm election, I think they're going to want to try to make these permanent. I think that's going to be really costly though. And so we'll sort of see where the Congress goes next on this.
John and Jim, thoughts on whether you think it will be made permanent, and if there are certain pieces of it that you think especially should be made permanent?
Yeah, I mean, that was an excellent explanation. I'm going to disagree a little bit with Katie. I don't think it necessarily needs to go all the way down to 8.5 at the top of the income scale. I feel like, in a nation that spends 17% of GDP in healthcare, saying no one should have to spend more than 8.5% of income on premiums at any income level seems actually very more generous than I would have gone. But I think Katie's right, that the gauntlet's been thrown. It's hard to imagine that sort of not staying, especially because, now let's be very clear about that. That is very hopeful in terms of protecting people in both urban and rural areas, Katie, expensive New York and Boston and things like that. It doesn't cover a whole lot uninsured. I mean, if you look at the cost per uninsured, which was astoundingly low in the ACA in a whole, it's about $10,000 per newly insured covered under that provision, because most of the money goes to people already covered. Now, that's a good thing. They need the money. But let's recognize that it doesn't do a whole lot to move us forward. That piece of lifting the cap does a whole lot to move us forward on coverage. I think something needs to be permanent there. I think something needs to be permanent to make it cheaper at the bottom, whether it's 150 or 200. I think we can do something. And, Joe Biden proposed moving people to gold as the benchmark rather than silver. I like that. I still don't think that's generous enough. I think if you look at someone who's below 3 times poverty, even a gold plan, that's a, you know, on the order of a, can be on the order of a $4,000 deductible. That's a lot. And I think we should think about even doing better for people sort of at the lower end of the income scale. And I do, once again, I'm not a huge fan of the COBRA subsidies. I feel like the employer-sponsored system has all these problems. We shouldn't be propping it up. I don't think they'll be made permanent because they're super expensive, but I worry a little bit about that as a bad long-run outcome. But I think in general, and then the other thing that I'd love to know Katie's view on this is, what about these prizes to try to get states to expand Medicaid? I mean, look, this is the sort of enduring political malpractice of the ACA, is that these governors are essentially turning down free money from other states to help their citizens. It's really bizarre. It defeats any theory of political economy I ever taught in my life. And now we're trying to throw these bribes at them that are actually, as Katie said, even more than just making it free. We're giving them more than 100%, but they're very short term. Katie can remind us how long they are. And I'd love to get thoughts about, are there any, I mean, this is, you know, how do we get these recalcitrant states to expand? I doubt this is going to do it, given the subsidies are short term. And where does that go? And it's a really interesting question.
Yeah, and you know, I think on the Medicaid question, so the sort of enhancement or the extra, you know, the carrot that you would get would be for 2 years. And the idea is that states that expanded would get a much more generous increase in federal matching for their non-expansion population. So I think when Kaiser Family Foundation crunched the numbers, it was sort of, if all the states were to do it, they would see a 2-to-1 return in terms of the sort of money that was being put up back from the federal government. So all things equal, you would think that would help get it done, but I don't think we're in that world. So what I'm super interested in, though, is, you know, you had Missouri and Oklahoma expand Medicaid through ballot initiatives. Based on the way the law is written, they should qualify for this enhanced Medicaid match. So I think other states, especially ones that might have been close, folks talk about Alabama, Wyoming, Kansas, maybe being on the cusp once again. I have a feeling they're going to watch Missouri and Oklahoma and see if that is enough to maybe get the job done or bring folks back to the table. I think we're also watching for ballot initiatives too, though, in 2022, which has seemed to be the only way to get Medicaid expansion done. So watching and waiting ballot initiatives in Florida, South Dakota, and I believe Mississippi. And so maybe that would sort of bring in that money, or maybe that'll get legislators to the table to try to take advantage of those incentives before. I don't know, but the truth is you can't do a ballot initiative in every state. And so what do you do in Texas or North Carolina or somewhere where you're not convinced they're going to do it? And, you know, I know folks have been sort of loath to talk about this so far. I do think at some point you could expand, you know, let folks into the marketplace, right? Eliminate the Medicaid coverage gap by putting folks into marketplace coverage. There's a lot of folks that don't want to do that. We think folks are, you know, people should be in Medicaid. They're better off there. At some point, though, I think it could get too challenging to really get states on board and bring them in to help their residents. So we'll see. I don't know if you have any reactions to that, or if we need to make changes to the program to make sure that that coverage really did work for folks under the poverty line. But that's one of the most obvious things to me, at least.
And Katie, you may have mentioned this, but how long is that pot sweetened for?
For 2 years.
2 years. Okay. So it doesn't give a lot of time for states who are watching others to decide what they're going to do, but it might be resweetened later.
It's enough to say, here's why you should do it, but also here's why you shouldn't do it, I think is the problem.
So let me ask a question, and John, maybe I'll come to you on this one first, about what is happening on the in-state implementation. So obviously, as we see more money coming in from the federal government, it gives states an opportunity, but also kind of puts more pressure on them with these funds to be able to get people enrolled and to get them enrolled in plans that are good for them. And you've written about, I know you've both followed kind of what the states have done, and you've written about choice architecture and what works and what doesn't work. So what are you seeing out there? What do you see states doing that you think is good, that you'd like to see more states doing? And what are you not seeing that you would love to see states doing?
Yeah, it's a great question. I mean, they're really, you know, one sort of advantage of the Fed sort of abdicating leadership of this the last few years is there's been more state innovation, states putting individual mandates in where they make sense. And I agree with Jim, the mandate may not have made sense nationally. I think it does make sense in some of these blue states and other innovations. And we see real heterogeneity in how well states are doing. California's just been doing well since the beginning. It's aggressive outreach. It's clear access. But I want to come to the really important point you made, Allison, which is let's talk about choice architecture. There's now a huge economics literature which shows that people are maybe, well, I thought it was obvious, but are terrible at choosing their insurance plan. And just making it gold, silver, bronze is not good enough. California has moved to standardizing choices, as did Massachusetts. Clearly, that's a better option. It's sort of the notion that people have the wherewithal to really optimize over $500 versus $1,000 deductibles is just not supported by the evidence. And when we did it in Massachusetts, there's evidence that increased satisfaction and quality of choices when we standardize choices. So then clearly states can move to more standardized choices and to better decision support. I have to have a caveat here. I'm a small part owner in a decision support company called Pickwell, founded there at Penn. But I'm not endorsing that company, and specifically, I'm just saying in general, we can do better in terms of supporting the decisions people make, these complicated decisions, both by standardizing choices, but also by having better support for individuals to make those decisions. These decision support programs aren't that hard, they aren't that expensive to implement, and I think they can really make a difference in terms of improving choices.
I want to ask one last question, and I want to ask kind of a wonky question of you, Jim, before we turn to the audience Q&A, because we're getting a lot of really wonderful questions from the audience. The American the recovery plan the rescue plan was passed through the reconciliation process, and I know you are a budget expert. You've studied reconciliation, and I want to know if you have thoughts as you look at how that law was kind of crafted and passed, and also what might come next, because now the administration is talking about a next reconciliation bill that could include health policy provisions. There is some talk about a public option, although maybe that's more talk than reality. So what do you think about when you look at the American Rescue Plan and you think about what might come next and using reconciliation as a tool? Are there pieces that you see that feel like are a good fit and maybe not a good fit for reconciliation? And what do you anticipate might come through that process?
Well, this is obviously a topic of great concern, but it's a little bit off health policy. I mean, I think in a certain way, our budget process, our budget reconciliation process is maybe kind of equally as broken as our political process, maybe reflecting of the brokenness of our political process in a certain way, is that the parties have both decided that reconciliation is a way of pursuing a partisan legislative agenda when they don't think they can get any cooperation from the other side. And so they both have used it to push things that the other side won't be able, doesn't support. And I think that's actually not what the idea of reconciliation was way back when. It used to be used to, believe it or not, for bipartisan deficit reduction bills that were hard to pass. And that was a way of getting them both to kind of agree on something and have it expedited through the Congress, but on a bipartisan basis. But those are years gone by. So where do we go from here? I think the administration will find, and there's a great temptation to try to do another reconciliation bill later this year for infrastructure, for maybe the public option, for all manner of different things they'd like to get done. My own guess and judgment is that that's going to be very tough sledding. That you have a 50-50 Senate and you lose one vote on anything and it's a different deal. And by the way, I mean, I don't mean, it's like cutting taxes for the Republicans. It's a lot easier to cut taxes when you're not paying for it. And in a certain way, it's a lot easier to create a lot of spending programs when you're not paying for it. And so is the next bill going to be a $2 or $3 trillion increase to the deficit where they don't have to pay for it with tax increases or other offsets? I doubt it. I don't think they'll have the votes for it. And so then they're going to have to pay for it, which means they're going to have to raise taxes. And even when you raise taxes on rich people, it's not that easy. So I think going forward, this is going to be tougher sledding. I don't mean this, I'm not rooting against it. I'm just saying as a factual matter. And so I think the idea that the reconciliation is going to make all things kind of easy for them to get done, I just don't see it playing out that way at all.
Thoughts from Katie or John on what to expect going forward before I shift gears?
Well, I think I'm more optimistic that there will be a big ACA plus up bill. I think Katie's emphasized the reason why, which is hard to make things go away once they're in place. I think, I think that to make it permanent, you need a funding source and a reconciliation. It will have to happen by reconciliation. You get 0 Republican votes. To make it permanent, you need a funding source, and there's 2 natural funding sources. There's tax increases on the wealthy, of which Biden's proposed a lot, and this prescription drug pricing reform, where HR 3 would save $450 billion over the next decade. So I think I don't know if we'll get everything Biden wanted in his plan, which would cost, I think, almost as much as we'd save in prescription drug reform, or maybe less now that we've already paid for the first 2 years. But I think I'm optimistic we'll get a permanent fix to the ACA through reconciliation before the 2022 election.
And I agree. I think John nailed it too. I think with the prescription drug pricing, that is the conventional wisdom at this point. Use the prescription drug savings to, be the pay for a lot of the coverage expansion under the ACA.
Although to be fair, that savings has been probably promised 8 times. As with all of the savings, it's promised 8 times over. But I think that's the most likely funding vehicle.
So let me, as I'm sure you all are used to, we've been sitting here and talking about access and coverage, and people are asking a lot of questions about affordability. And so you're starting to kind of move into that space, thinking about prescription drug prices. Let me just ask you a few of these questions and then hand it over to you for your thoughts. So the one on prescription coverage comes from Eric Ellsworth. A lot of the focus has been on the uninsured, but there are also a large number of underinsured. Oh, no, this one is on generally underinsured Americans, mostly in ESI, but also in other programs, who are struggling with healthcare costs. Can you talk about what the ACA and related policy can do for them? And then this one's on drug pricing from Carl Schmidt. What can be done to make insurance work for people once they have it? Deductibles and cost sharing are still very high for many, making it difficult to afford prescription drugs. What about capping copays or first dollar coverage? So maybe you could talk a little bit more about kind of what's teed up for that. Another question coming in from Sabrina Corlett. If ARPA is made permanent, we make it essentially pain-free if premiums rise in the individual market. What do you think this means for state policymaking and the incentive to pursue cost containment initiatives? And then Nancy Weinman, how do premiums and copays and coinsurance and coverage on ACA exchanges compare to traditional Medicare and Medigap plans? So thinking about comparing to other places in the market. So that's a lot. They're all related questions. So I put them out to you to kind of pick off pieces of them as you wish. Who wants to jump in first?
I'll jump in.
Thank you.
So let's start with actually Sabrina's point, which is a really good one, which is, look, there's actually really important economic research showing that while the way the ACA subsidies were set up maximizes affordability protection, it minimizes cost control because there's no cost incentives to once you get above the cap. And if you make everyone capped at 8.5% of income, then for virtually everyone in the exchange, they'll be subsidized. And so I think it's really critical that we learn from the experience in Massachusetts, and it comes to your earlier question, Allison, about structuring exchanges, that we do more structured competitive bidding and more structured contract negotiation among the plans on the exchanges, that the exchanges take a more active role in being active purchasers. They can't rely, if there's no income cap, they can't rely on consumers as purchasers to impose cost controls on insurers. They've got to rely on selective contracting. Now, there's still some consumer pressure because it's tied to the second lowest one, so everyone wants to be below that. But I think in general, states need to be more aggressive about selective contracting. And here it ties so wonderfully to Jim's earlier point, which is there's auto enrollment, and you say auto enrollment is going to go to the lowest cost plan. That puts huge pressure on plans to bring their costs down. In Massachusetts, we had essentially pretty much free insurance under Commonwealth care. Costs were almost flat over the first 3 years because we used selective contracting and auto enrollment to put the lowest cost plan be the one people are auto enrolled to. And that had a huge effect. So I think there's just sort of natural package here of dealing with the sort of lack of price control through making everyone subsidized by using the defaulting of people into the lowest cost plan. And that sort of is another way to put cost pressure on plans. I think in terms of general cost sharing, once again, I'll mention again, I think there's been too much focus on premiums, not enough on costs, out-of-pocket costs here. And I think that needs to be addressed in the next round. I actually think every dollar, honestly, to my mind, every dollar that's taken away from subsidizing premiums for higher income people and put into subsidizing cost sharing for low income people is a dollar well spent. Politically, it's not a dollar necessarily well spent, but I think economically it is. So I think we need to do more there. You know, in terms of drugs in particular, I think we need a broad prescription drug reform. And here, let me just mention, you know, I think it's very important to emphasize, the big debate over HR3, which is going to include, you can sort of paraphrase the debate as sort of savings today versus innovation tomorrow. And CBO's even come with a number. Amazingly enough, they said that if you pass HR3, we'll have 30 fewer drugs over the next decade. That's a false choice. Because in fact, if you took even a fraction of the savings from HR3, and I realize, Katie, I'm overpromising those savings. If you took a fraction of those savings and invested it in public R&D, as emphasized in my book with Simon Johnson, Jumpstarting America, the returns to public R&D are so high that by essence, by my MIT colleagues, if you take a quarter of the savings from HR3 and put it in NIH, you'd have 80 new drugs over the next decade, more than the 30 you'd lose from lower public innovation. So there's a false choice with HR3. There's notion of, well, if we save money, we'll get less innovation. That's absolutely wrong. The way to get more innovation in drug space in America is more public investment in the pharma space, and we can fund that with the savings from HR3.
I guess I'll jump in here. This is a very large and complicated topic, and so my 1 minute, I don't know if I can do justice to all the different things that are in play here. But
wait, we're only supposed to talk for a minute?
No. I want to only go for a minute so we can get to other questions too. But I guess what I would say is that I think the Biden administration and the Democratic Congress are going to have to decide, and I think they probably will decide, what's their theory of cost control to try to help on all of these kinds of questions. I think on drugs, their theory is pretty clear. They want to move forward with some more price limitations. But it's not that clear on the other big sectors, on hospitals and physicians, and exactly how they would bring more discipline. Remember, the Affordable Care Act really had sort of three ideas. The president often would say, we're trying everything to see if we can get more discipline in the system. And candidly, all three, I think, are kind of falling off the waist, falling off at this point. I mean, there's lots of worry that alternative payment models in Medicare are kind of coming up short of what they had hoped for. The Cadillac tax was killed, and IPAB was killed. And so the only thing remaining really were the cuts in Medicare payment rates that were just sort of implemented. And that's sort of been around for a long time and tried and true. And so I wonder a little bit about where all this is going. What's the theory of cost control? I think for a lot of folks, they would like to just get to more rate regulation. But how do they go about getting there? It's not, I don't see a clear pathway at the moment, but maybe they'll develop one.
Jim, can I tuck in one other question there for you from Joel Ario as you're thinking about it? So he asked, whatever happened to Republican support for something like Wyden-Bennett as a better vision than the current ESI market? It's tangentially related, but as you think about kind of, where.
Yeah, I mean, that was offered back before, of course, the Affordable Care Act passed. And the idea was to allow for state innovation to sort of move forward on how to really systematically address the entire insurance market in a way that made sense across a whole state. And if I'm remembering the reform right, and they kind of incorporated some of that into the ACA through the state waivers, and I think that's sort of where they think they took care of that idea. And of course, that has been taken up very, very minimally by the states. And so I think at this point, it might be a little bit of a dead end to try to propose that because of so much existing policy that's already sort of standed up and kind of maybe a little bit in the way of states being able just to start from a lower baseline.
Great, thank you. Katie, on the question of cost control and affordability.
Well, I was going to actually have a lot of thoughts on that, but I do want to make one point that I really want to punch on sort of standardized plans or out-of-pocket costs in particular. So I think one way to think about this, and for our state friends and maybe federal friends who are here, I think there's a real equity component to how we plan design and cost sharing that we have overlooked for a very long time. And so the way we design plans, whether it's exclusions, whether it's higher out-of-pocket costs, whether it's drug tiering, given the moment that we're all in and sort of the stated commitment from insurance companies and industry and all of us here to equity, I think there's a real moment to look at designing standardized plans that I don't know, help communities of color better manage and control, diseases that are more predominantly affecting those communities, those kinds of, what are we doing on diabetes? We should be covering ancillary services for PrEP. I see Carl Schmitt's question, all these types of things. And so, yes, it's kind of nebulous, high out-of-pocket costs, but I just want to punch on that point that we have an opportunity in front of us also to make sure that the folks who need benefits the most are actually getting them and designing plans in a really smart, thoughtful way.
Great, thank you. So as we think about, I mean, this is a somewhat related question, and coming from Monica Van Buskirk at Colorado Connect for Health. She asked, how will we know we're doing better at having people select plans? What looks like the right plan for customers? So whether you're thinking about that from a, kind of a affordability perspective or an equity perspective, how will the states know if they're doing better? Katie, do you want to start on that, since you were?
That is 1,000%, I think, a John Gruber.
Okay.
I will defer. Thank you.
This is what I spent much of the last decade thinking about with my co-author Jason Abeluk most frequently. I think at a minimum, it turns out a pretty good measure is, are they cost minimizing? If you add up what they pay in premiums plus what they pay out-of-pocket costs, is that as low as it can be? It turns out we've done much fancier, ivory tower kind of welfare measures, but it turns out that's a pretty good summary statistic. And a couple of findings from research that are quite interesting. First, we did a cool research study across school districts in Oregon where there were different choices of number of options. We found this number of options got above 3 or 4. People's choices got worse. And the reason was because these school districts were pretty good at making sure they offered a couple plans that were good for everyone. And then they'd start to specialize and say, well, let's have a plan for the very healthy or a plan for the very sick. And the problem is people wouldn't choose the right plan for them. So all you do is just make all choices worse by adding these options. The other point we found is that's quite interesting, and I think for the state people on the call to think about, in my most recent work with John Kolstad and Ben Handel at Berkeley, we found that combining decision support with a live agent actually really improves choices. And then what's cool about that is the agents seem able to understand things people care about besides costs. So the problem, of course, with just minimizing costs is, what about network breadth? Maybe minimizing costs leaves people in a too narrow network. It turns out when you give agents decision support, they manage to help people make better financial decisions without giving up what they like about network choice. So something I think really for states to be thinking about, especially if we start to get a little more resources for exchanges, is to be thinking about combining really good decision support with more human support to help people choose plans, and that may be the best of all.
Great, thank you. We have about a little over a minute left, so I want to give you each a very, very short moment to share final thoughts for people. What do you, as you think about the individual market, as you think about coverage going forward, what do you hope to see, and what should people be thinking about? John, why don't you dive in first?
Go individual market. I think it's got a lot to offer. Let's not forget, let's never lose sight of the fundamental improvement made in life in America by having non-discriminatory insurance available to everyone. Now we just need to make sure it's affordable for everyone.
Great, thank you. Jim?
We have 20 million people that are already eligible for coverage that are not taking advantage of what they're eligible for. And I think focusing on that for a year or two would be a good thing to get that number down, because I think it would stabilize things quite a bit.
Great, thank you. Katie, the last word is yours.
I think it's a really exciting moment and sort of great to be here with all of you thinking about these next big questions. It feels like we are moving forward for the first time in a while, and I'm excited to sort of see where it goes and continue working on these things that we sort of all agree on here. So thanks for hosting, Allison. It's been a great conversation. Really lovely with John and Jim.
Can I just add one? I want to ask one last word.
Please,
okay. For the state exchange, I'm sure state exchange people on the phone are on the call aren't shy, but remember, there are people like the three of us on the call who want to help. Don't be afraid to reach out to the broad network of experts to really get help as you think about next steps for your state.
Thank you. That is a generous offer. I hope they take you up on it. I want to thank everyone for being here today, and thank the three of you. This has just been really fun for me to hear from you and to hear you all engaging with each other. So I really appreciate your time. And thank you for everybody for joining us for today's panel.